everyone. My name is Doug Koch. I'm from the Cullen Eye Institute at Baylor College of Medicine. I'm presenting a new episode of IOLs, What Every Surgeon Should Know, and I'm so happy to have our guest speaker today be Karolinne Rocha, who is professor of ophthalmology in Melosi Endowed Chair. She has their refractive surgery and cornea program. She has their fellowship. And of course, she's at Storm Eye Institute, Medical University of South Carolina. Well, welcome.
Thank
Sure.
you. This is great.
Our topic today is an interesting one, I think, because they're an interesting part of our practice these days. Tell us a little bit. What is an enhanced monofocal?
I know, and it's a really, I really like this category of lenses. I know it's a new category because it gives patients a fantastic pseudo accommodation, but are monofocal lenses. They're in the monofocal category, right? With the optics, basically they change that perfect aspheric surface of the lens, right? It's what we call high order asphere. And basically, there's lenses with different mechanism of actions. One you see is slightly changes in the curvature, continuous changes of the curvature from the periphery to the center of the lens. And that can be in the anterior surface of the lens or in the posterior surface of the lens. So these are, two lenses, and there's a third one that is actually based on spherical aberration. And why is that important? Because those patients, they have really great distance vision, but enhances the intermediate vision, gives you a good, range to extend the depth of focus.
Great. So in the US, we have really three models that kind of fit that, right? Uh,
Yes, that is correct.
we have the Invista Aspire, we have the Tecnis Eyehance, that was the first one to have, and then we have the one from Rayner as well, right?
Yes. So the eye hands has changes in the anterior curvature of the lens, right? The high order sphere, right? With continuous changes of the curvature from the periphery to the center with that slightly add power centrally. Basically, is slightly steeper centrally, right? The aspire, the changes are in the posterior curvature of the lens. Very similar is that in that center 1.5 millimeters that you see changes in that posterior curvature. And then clinically, it's exactly what we see. Patients, they see great for distance with that slightly better intermediate vision.
Right.
And the third one is based on spherical aberration, right? We know that if you have residual spherical aberration, you can increase the depth of focus, but that fine balance, right? That you can increase depth of focus without compromising the distance vision.
It's really interesting that we've come at it from the front, we've come at it from the back, and we've come at it from a different direction. And I like the point you make about higher order spherical aberration. People are always asking me, well, is it just increased fourth order spherical aberration? No, it's sixth, it's eighth. It's because the changes are very subtle and they're in the center. So it's a different way of thinking about it, isn't it? So what's the benefit of this to our patients compared to a standard monofocal? What is it? What can we expect our patients to get?
Yes, I think those lenses, they give a really great functional vision. Patients now, most of the time, they're in the computer, their phones, and again, it gives that continuous vision from the distance to intermediate. So I think it's definitely great options for patients with normal eyes or patients that are not candidates for diffractive technology, right? Someone with a slightly epiretinal membrane or some drusen or some patients that were definitely more conservative that we don't want to use diffractive optics. I think I always like under promise, over delivered, right? Because I think some patients, and we know with binocular summation, both eyes, patients actually they see one line better, right? It's important to report monocular depth of focus curves. But when we're measuring binocular, we know patients they see one line better, and it will be surprised. Some patients they can sometimes even read smaller prints without glasses with this technology. But again, it's in the monofocal category. You don't want to promise, glasses free, and but you'll be surprised sometimes.
Right. I love this category for the doing the dominant eye first. If they love their distance vision and if they get a lot of near from it, I can probably do something similar in the other eye rather than go for more monovision or a trifocal or something. How do you approach this with your patients?
Very similar. I usually target plano or first minus, maybe the first minus dominant eye first. And I like to see the patients post-op. And then you can fine tune because if the patients, if they want a little more reading, right, with the same category, you can offset just a little bit minus 0.5, minus 0.75. And it's what is really nice about this category is that the distance vision is still really good. If you target in the non-dominant eye, minus 0.75, that patient will see 20/30, 20/25, and they can definitely benefit from this extended range.
They really have enhanced my practice a lot in terms of what I can offer patients. Are there any contraindications in your hands with these
Yes, I
lenses?
think
Are they for every patient who would get a monofocal, or
I
are they what
know.
you wouldn't want to use them in?
Yes, I think it's important to look at the topography, right? For example, if someone had a myopic LASIK 10 years ago with a very small optical zone, that patient has a lot of positive spherical aberration. I may just want to do a lens, with negative spherical aberration. Irregular corneas, I may want to do an aberration-free lens. Someone that had hyperopic LASIK, you can match depending on the topography. Although those lenses they are very forgiving, actually, right? I think we definitely need more studies in those different categories. But I still avoid, someone, for example, with keratoconus and a lot of coma, then I probably will do just an aberration-free lens.
Yeah, I do the same. I've heard some discussion about occasionally surgeons have reported unhappy quality of vision with these lenses. Personally, I've never experienced it. But so I am cautious, as you say, the irregular corneas, something doesn't seem quite right. And certainly corneas with a lot of already negative spherical aberration or a lot of coma, maybe you're better off with a more uniform optical surface. But it's been a wonderful addition to our practices.
Yes, yes. I think again, it's a premium option for eyes, right, that are not candidate for, the full vision range lenses. I think the patients are very happy with this technology.
Well, that's was really illuminating, and really appreciate your taking the time to talk with us about this.
Thank you so much. My pleasure.